Hi everybody, welcome to this video. I will be talking about some high-yield topics in cardiology. So start off by going through hypertensive complications. So first question is, what are the hypertensive complications that present as severe hypertension greater than 180/120 with retinal hemorrhages, exudates, or papilledema? And that would be malignant hypertension, so that's a hypertensive emergency. So again, just to repeat, that's retinal hemorrhages, exudates, and papilledema, and that's going to be malignant hypertension. The next question is same scenario. Person comes in with severe hypertension, 180/120. In this case, they have cerebral edema and non-localized neurologic signs or symptoms, and that's going to be hypertensive encephalopathy. So that will be hypertensive encephalopathy, and that's also a hypertensive emergency. What is the most effective non-pharmacologic measure to decrease blood pressure in patients with significant tobacco alcohol use with a BMI of 22? Don't get confused here. Even though they are using tobacco and alcohol, the most significant way to decrease blood pressure is going to be the DASH diet. So remember that. And if they are obese, which this person is not obese, but if they are obese, then the most effective treatment is going to be weight loss. What is the initial treatment for a hemodynamically stable patient with atrial fibrillation with rapid ventricular response? That would be rate control. Sorry. That would be rate control. Sorry about this. So that'd be rate control. What is the diagnosis in a patient post MI day 5 that presents with acute onset chest pain and profound shocks without signs of congestive heart failure? That would be ventricular femoral rupture. What class of drug should be administered within 24 hours of an MI to limit ventricular remodeling? That would be ACE inhibitors. How do the following parameters change in left ventricular systolic dysfunction? Cardiac output is going to decrease, SVR will increase, and then left ventricular EDV is going to increase as well. What are the analgesics associated with decreased metabolism of warfarin, aka increased bleeding risk? That would be acetaminophen and NSAIDs. So what is the likely diagnosis in a patient with implantable pacemaker that presents with peripheral edema, JVD, and hollow systolic murmur? Left lower sternal border with clear lungs on auscultation. That would be tricuspid regurgitation. The right ventricular lead of an implantable pacemaker passes through the tricuspid valve to enter the right ventricle, and that may damage the leaflets. So just remember that if a person has an implantable pacemaker and they present with peripheral edema, JV, and a hollow systolic murmur on the left lower sternal border, that's probably tricuspid regurgitation secondary to the pacemaker going through the valve and damaging the leaflets. Okay, next question is, what is the likely etiology of an NSTEMI patient with chest pain, agitation, and dilated pupils? That would be cocaine intoxication. Treatment of NSTEMI due to other causes except beta blockers are avoided, and IV benzodiazepines are administered. So that alleviates the psychomotor agitation and sympathomimetic effects. So once again, do not give beta blockers. What are the strongest predictors of, the strongest predictors of abdominal aortic aneurysm rupture are large aneurysm diameter, rapid rate of expansion, and then current cigarette smoking. So that's large aneurysm diameter, rapid rate of expansion, and current cigarette smoking. What is the most likely diagnosis in a patient with a short systolic murmur at the cardiac apex that disappears with squatting? That would be mitral valve prolapse. So squatting increases preload and left ventricular volume, decreasing the intensity of the murmur. So squatting increases preload and left ventricular volume, which is going to decrease the intensity of the murmur. The current indications for operative endovascular repair of an abdominal aortic aneurysm include rapid rate of expansion, presence of symptoms, and aneurysm size greater than 5.5. Sorry about this. My computer keeps zooming in when it's not supposed to be zooming in. I think because I'm double clicking. by mistake. Okay, so what is the initial treatment of choice for a patient with ventricular fibrillation? Of course, you're going to do defibrillation. So defib. What is the likely diagnosis in a patient with a wide pulse pressure and pounding heart sensation, especially in the left lateral decubitus region? That would be aortic regurgitation, and that's a diastolic decrescendo murmur. So the left lateral decubitus position brings a enlarged LV closer to the chest wall, increasing the awareness of the heartbeat. So that's why they have that pounding heart sensation. What is the most important risk factor or factor for survival in a patient with an out-of-hospital sudden cardiac arrest? That would be elapsed time to effective resuscitation. So inadequate bystander CPR, prompt rhythm analysis, and defibrillation in patients found to be in ventricular fibrillation. What is the likely diagnosis in a hypotensive patient requiring IV fluids and pressors to maintain blood pressure that develops cool extremities and the skin findings below? Skin findings aren't shown here, but that would be pressor-induced vasospasm such as norepinephrine. What is the likely diagnosis in a hypertensive patient requiring IV fluids, pressors, BP, to maintain BP that develops cool extremities? Remember, pressor-induced vasospasm such as norepinephrine, high yield. What is the likely diagnosis in a young woman with recurrent headaches, significant hypertension, and subauricular systolic brewery? Subauricular systolic brewery, that would be fibromuscular dysplasia. Fibromuscular dysplasia most commonly involves the renal and/or internal carotid arteries. So the treatment is going to involve antihypertensive medications such as ACE inhibitors, a definitive management of renal artery stenosis with surgery or PTA. Patients with LDL greater than 190 are recommended to begin high-intensity statin therapy. What is the likely diagnosis in a patient that is being treated with furosemide and nitroprusside for a hypertensive emergency that develops confusion, agitation, and seizures? That would be cyanide toxicity. So confusion, agitation, seizures, cyanide toxicity, confusion, agitation, seizures, cyanide toxicity, and that's due to nitroprusside. So it's most common in patients with renal insufficiency. What is the most likely cause of bradycardia, AV block, and diffuse wheezing in a patient that has attempted suicide? That would be beta blocker overdose. Remember, you're not supposed to give beta blockers to patients who have asthma because it constricts the airways. So same process here. You're going to have diffuse wheezing because of the beta blocker overdose. Other symptoms are going to include hypotension, hypoglycemia, delirium, seizures, and cardiogenic shock. What is the likely underlying etiology of atrial fibrillation in a patient with weight loss, lid lag, and a tremor with outstretched hands? That would be hyperthyroidism. So Chad's VAS score, we'll go through this quickly. It's to assess thromboembolic risk in patients with non-valvular atrial fibrillation. You're looking at congestive heart failure, hypertension, age greater than 75, 2 points for that. Diabetes, previous stroke, TIA, or thromboembolism, 2 points for that. Vascular disease like prior MI, PAD, or aortic plaque, age 65 to 74, and sex female. Okay, so what is the initial therapy for patients with atrial fibrillation due to hyperthyroidism? Hyperthyroidism, that would be beta blockers or propranolol. So initial therapy for patients with atrial fibrillation due to hyperthyroidism, you're going to give them beta blockers such as propranolol, because that helps control the heart rate, and hyperadrenergic symptoms should be continued until the patient becomes euthyroid with thionamides, radioiodine, and or surgery. And last point here for this video, patients with beta blocker overdose that have refractory hypotension to atropine and IV fluids should be started on what medication? They should be started on IV glucagon. So that's it for this review. I'll have more cardiology reviews coming up shortly. Thank you so much for watching. Have a great day. Take care. Bye.